Good morning. Uh, I'm Zhongnan Kan from TSVS in Taiwan, and it's my great honor to be here to have our friends, Professor Li Xinfu and Brian Yang, to cooperate, moderate this section. And we have lots of commenters, Professor Chen Yiming, Chen Taiwei, Xue Shukai, Xu Rongbing, Xu Rongchen, 黄兆康、许志祥、吕梦莹、王维婷、Michino Tang、光明堂、Joseph Lo、Soracha Rukapan、Jingno King、Tun Yup Tang, and our Ivers commenter will be Chen Bolin. And it's a great meeting to meet everybody in here. But now the lab demonstration is not coming in not online, so I will first invite Professor Li Xinfu to give us a mini lecture. His topic will be my strategy to treat severe balloning lesion. It's from Taiwan. If you're ready, please let's welcome Professor Li Xinfu.
Good morning, my colleague and my friend. Nice to meet you. Today I would like to show my practical approach, my strategy to treat severe BTK lesion in Taiwan. My talk will have a 3 parts. This is my 3 parts. First part is revascularization strategy and evidence. And the second part is endovascular technique and the access. And the third part is modern tool for BTK intervention. So this is this in my outlines. So the first part, revascularization strategy. The complete revascularization methods. The evidence from this study, we can see the zero patent tibial artery had only 56% 1 year limb salvage. With one artery, limb salvage could improve to 73%, and the 2 artery is 80%, and 3 artery was 83%. So the message is clear: to achieving more patent tibial artery translate into better clinical limb outcome. So our goal is to achieve to reverse more tibial artery if possible. However, if it is not possible to achieve total revascularization, it actually could be happen in the real world practice. So with no doubt, angiosome guide revascularization is effective to improve limb outcome and reduce amputation risk. But how about the indirect revascularization? From this study, we can see the direct revascularization was similar to indirect revascularization, because indirect revascularization also have an existing distal collateral vessel to supply the wound. So another issue is how far should we revascularization to? This is the pedal arch classification. We can see the type 1 pedal arch is intact, but the type 2, type 3, the pedal arch was not intact. And how far should we revascularization to pedal arch? From this study, the patient were treated by bypass surgery, but the pedal arch may be intact or not intact. So they also have analyze the pedal arch, the impact of pedal arch. So the data tells us the quality of pedal arch did not influence the patency or the amputation risk, but the rate of healing wound is influenced by the quality of the pedal arch. And how about the endovascular treatment? We can see the Dr. Nakama had published this paper, and the paper also shows a similar result. We can see if you did the pedal artery intervention, the amputation risk is not different from non-pedal artery intervention, but the wound outcome was different. So if you did pedal artery intervention, the wound heal will be better than non-pedal artery intervention. So just a short summary, we can know from evidence, we can see the revascularization strategy should be try to the best is the total revascularization, but the angiosome guide or indirect flow revascularization also have evidence to reduce the amputation risk. So in addition, my practice is do my best to reverse bar to pedal arch because pedal arch flow could improve the wound heal. So my second part was talk about the endovascular technique and the access. So for BTK intervention, I would like to do anti-grade common femoral artery puncture for almost case because from this access we can have a better torque device delivery and better clear angiography also. So in my practice, I always use 4 guide for femoral artery puncture, but for a few cases like a very obese patient, I would like to use also some guide, but you have to be careful for a patient with a high common femoral artery bifurcation that may make the complication of retroperitoneal bleeding. So this is my algorithm proposed by me for causing BTK lesion. I think some guidelines have also algorithm for BTK intervention, but this is I think is more simple than published algorithm. For a short CTO, of course, the rate wire crossing, but for a long CTO lesion, I will try anti-gray wiring, even with knuckle wiring. But if the wire is not into the distal lumen, I will shift to bilateral approach. Bilateral approach, and we should be consider the retrograde access. Most of the case, we can use pedal access, retrograde puncture, and maybe we should consider pedal parental loop and the transcollateral route, and even for extreme case, we can use digital puncture. However, if no option for this case, we should consider different arterialization. This is the algorithm. Another guidewire choice, I just recommend just familiar few wire you in your daily practice. So I just classify 18 or 14 wire, and then divide it into the workhorse or CTO guide wire. I think the workhorse wire have to be hydrophilic with strong support, and also you can perform the knuckle wiring. This is my guide wire installation. And for bilateral approach to achieve rendezvous, I think almost the technique was reverse cut can be achieved success. And you should also be familiar for cut double balloon or other technique. And for BTK region, we also have some difficulty, like uncrossable and undilatable region. So maybe we have to use rota operation, middle cracking, intended subintimal crossing, or guidewire extension, through and push through technique. So this is my algorithm for approach the BTK region. So now I will show some case and by my practice for retrograde access. This is the most common situation. Retrograde puncture for pedal access. The target was dorsalis, pedis, and tibial artery. So most of the case I use fluoroscope guide, use the tube middle vessel in the line, like this picture. And I use the 28 gauge middle V18 wire, keep the adequate anticoagulation, local pain control, and use the vasodilator to prevent spot. And you can see the image, you can see the contrast here, and use the full scope guide retrograde puncture for retrograde pedal access. And for some extreme case, we maybe use digital access. It requires very high demand operator skill. You can see the metatarsal artery retrograde puncture, and we can also puncture the parental artery and achieve success revascularization. So the other retrograde access is the pedal parental loop, because the anatomy dorsalis pedis connect to pedal parental loop and connect to lateral parental artery. So this is anatomy to connection. So always we can use OTW balloon is possible. Of course, it is possible, but for very complex case, maybe we can use microcatheter to help coercion. For this case is total occlusion since popliteal artery. So the ATA and the PTA were also total occlusion. So this is our revascularization sequence. We from the popliteal to ATA and to dorsalis pedis through pedal parental loop and to the PTA from the pedal parental loop from the distal PTA and to the proximal PTA. So if you did not use microcatheter, you just use the OTW balloon catheter, it's not possible to close like this case. So so you can see the we for PTA we use the bilateral approach over this total occlusion, this part. So at least we can use Kingston balloon for ATA and PTA, and this is the final angiography. We can reconstruction all the ATA and PTA and the pendle loop. So another some case we use transcollateral approach. Transcollateral approach, because the transcollateral vessel was very tortuous, so the support is not very good. But for some cases, you have no choice. You maybe use the transcollateral vessel. We have to know peroneal artery have a perforating branch to the tibial artery and the posterior tibial artery. This branch is existing for everyone. So you have to recognize this perforating branch is maybe important for transcollateral approach. So we can use this case to reverse the ATA. Another transcollateral is not the existing vessel. So you should use the DSA to recognize this very small branch. Like this case, we can see there is a very small branch to the dorsalis pedis So we can use this small branch for retrograde attack. So we can successful revascularization this case. I will to show the some specific situation. Like this case, this is the ATA total occlusion. The guidewire could be closed, but the many device, many method could not be closed. So we just I just use the middle quaking to the calcify lesion, and you can see the image. We can do many times over middle quake, either anti-grade and the retrograde many times. So the micro case that can be successful pass. So at that time we can change it to rotor wire and to do rotor operation for this case. So this is the final angel. So for some specific condition, special BTK lesion, we may make unclosable and undilatable lesion. That we have many strategy to overcome this difficulty. So how about the modern tool for BTK intervention? For vessel preparation device, we know we have an accelerator, we have an IVL, and the cutting balloon. However, this device just can improve the procedure success, but now the current evidence did not show the very clear long-term clinical benefit. So this tool was just for lesion prepare. So how about the drug coating balloon? We know the paclitaxel DCB have a heterogeneous result. We know the Medtronic DCB was not good, but the bar DCB seems good, but heterogeneous result. But now we have a limit-based DCB was under investigation. So we in the future we maybe see the new evidence. And how about the stent? Of course, the dry routine stent or BVS is superior over the bare metal stent. However, even dry routine stent or BVS stent, this study will conduct in very selected region with focal, not a very long region, calcified, not a very calcified, not CTO. So this data could not be applied in real world practice. So this is my conclusion. Just I think the complete multi-vessel BTK revascularization is good, but the angiosome guide integrate revascularization for at least one inflow line to the foot is good for every patient, could improve the limb outcome, reduce the amputation risk. However, if do your best, if you can do reverse pedal arch, you can improve the patient when heal. So I think we can try our best. And should be familiar with all retrograde technique, because most of BTK lesion was a long CTO. It's very difficult just to use anti-grade caution. If we just for simple case is okay, but most of difficult case you should use retrograde technique. So familiar all this retrograde technique will conquer this complex BTK CTO lesion. This is my final slide. Thank you.
Thank you. Xin-Fu gave us excellent talk for his experience for his baloney lesions. So, any recommend or suggestion from our recommender? If not, that us change the channel to the Singapore. Thank you, Professor Lee.
Can you hear me? Have you all unmuted us?
Hello.
Hi, good morning. Can you hear me?
Morning. Can you hear us? Hello, Singapore.
Oh, hi. Yes, I can hear
Hi.
you now.
Hi.
Hi, good morning.
Morning.
Morning. I'm Darius. I'm from Sengkang General, Singapore. And I have Dr. Kapana with me as well as Dr. Gihan, my fellow, and my nursing team as well in Boston with me as well today. We're just going to show you the case that we're doing this morning.
Yes, please.
Before I start, maybe I just going to quickly talk about the agenda. I think the plan was to do an orbital showcase today. But for last minute logistics, we are unable to get Abbott on board with us for the live case. Boston is with us today. Next slide. Next, please. Thank you. Next one. Okay, I have Mr. Johamad. He's a 67-year-old gentleman. He just came in about 4 days ago, saw me in clinic. He's a chronic smoker, 2 packs per day for the last 4 years. He's having heart disease, prior PCI and CABG. EF of 30% in 2023, chronic kidney disease. He came to me with worsening claudication of his lower limbs for the last 6 months. And now he has right lower limb rest pain, and that's why he came to see the physicians. And that has been lasting him for the last 2 weeks, affecting his sleep. Okay, next slide, please. So our patients in Sengkang gets an arterial duplex and ultrasound preoperatively. This gives us an idea and a roadmap to what we need to do for the patient and let us devise the strategy. So giving this an AO scan, our plan is to do a contralateral approach from the left groin. Because of his CKD, we will be doing CO2 angiography. For his pen pop, you can see that there are multiple levels of severe stenosis of the SFA as well as the popliteal, and it's heavily calcified. Plans to do a 7 French sheath 45 from the left groin, then V18 as a workhorse wire, Bernstein 2, and then we'll do an IVUS once we cross. And once upon successful crossing, we would tend to we routinely put in an F6 filter for our jet stream arterectomy, and the choice of arterectomy in this case will be 2.4, 3.4, 2 passes, and then subsequently we'll use a high pressure balloon, and then we will retreat it with a paclitaxel drug balloon. For the BTK, most of the time when it's rest pain, we turn to the left, leave it alone. If the hemodynamic flow in the SFA pop is reasonable, we only provide the BTK to improve the outflow if it's needed. Okay? All right, let's go to the angio pictures, please. So we'll cross the lesion, right? We're waiting to put in the F6 on that stream, but let me show you the diagnostic angiogram first. Could you see the angios?
Not yet.
Okay. Sequence 1 first, please. Thank you. So I'm going to cross from the left groin. He has acute aortic bifurcation. That poses a slight challenge when we're crossing, but we managed to cross across it. Next one. Nope, sequence 6. So this is the run from the CFA. You can see that it's a heavily disease on the SFA on the origin as well, the osteo on the SFA. Next run. And this is persistent throughout the whole SFA all the way down to the ductal canal. Next one. And then there's also some stenosis at the P1 region as well. P2, P3 seems to be relatively patent. Okay, next one. Sequence 16 and 17, right? Next one, nope, next one. 18.
Sequence 18, 19.
And then this is the diagnostic angiogram for the BTK. Some disease in the tibial vessels, but primarily patent. Next one. And the foot run is actually intact. So he primarily has inflow disease, and that's what we plan to do for his rest pain anyway. So we'll move on to show you the IVUS of the SFA pop. Yeah.
You want to show them the crossing first?
It's okay, no need to. Okay, let's go to the IVUS pictures, please.
Okay, IVUS go live.
Yes, please.
So this just, we're just doing a pullback run from the proximal ATA upwards.
So this is ATA coming up to the popliteal and the SFA. You can see that it's true lumen crossing throughout the whole lesion. Calcification grading wise is about grade 2. It's not super heavy calcified. Some parts is there is some medial calcification and some intraluminal calcification, which is a very good case for nephrectomy, calcium debulking as a calcium modification. We also routinely use IVUS when we do angiograms in our practice nowadays, where we actually use the
IVUS stop?
to show that it's true lumen as well as for vessel sizing. We're going to just show you the vessel sizing. So to our surprise, this is a very small man. He's an Asian man that's about 55 kg, but his vessel size are relatively big actually. His CFA measures about 9 mm, 8 to 8.5. SFA is about 6.5 to 7, and the popliteal is about 6 mm as well. So relatively big vessels in the Asian population, and we're glad that we use an IVUS to size it so that we can do the appropriate balloon dilatation with reference to the IVUS. So right now we're going to put the NAV6 in the distal popliteal P3 where it's patent with no thrombus or any calcifications. Neil, can you go down to the P3 to show? Thank you.
Can I ask you a question? Can you hear me?
Let's go back to the angio pictures, please. Thank you.
Can you hear us?
Yes, I can hear you.
Yes, Brian from Hong Kong. So look at the IVUS. It doesn't seem to be a lot of calcium. So after the IVUS, how do you decide whether you use a jet stream, like you're going to, or the orbital?
Sorry, give me a minute. Can you turn up the volume? I can't hear them.
You'll go down south.
Sorry, can you say that again? Sorry.
I think previously, initially, you planned to use the orbital, but now that after the IVUS, do you think it's a good idea that you use the jet stream now rather than the orbital?
I think the purpose of our orbital and the jet stream does the same kind of purpose where there's calcium debulking. Orbital is sort of a sending motion and it's trying to scrape off the calcium. Jet stream is a cutting blade where the calcium is being taken off. In our practice, both orbital and NAV and jet streams, we actually put a NAV6 filter. Yeah. Even though beneath the IFU orbital, Dole claims that the filter is not really required. So I think in terms of efficacy, in terms of device preparation for jet stream after an orbital, we does it the same way. So the difference between the two atherectomy devices is probably not much in our practice itself. If there are you do not have a filter, then orbital could be possibly a consideration if you need to treat long SFA calcified lesions without the filter itself. Of course, there are other centers that does jet stream without the filter, but in this case, because there's no total occlusion, and it's just highly stenotic SFA pop lesions, and we will probably want to put a...
How about the vessel size? Does it sway you one way or the other? That the potentially orbital will give you a bit more gain from a larger vessel?
I think the jet stream 2.4, 3.4 was probably adequate to address the size of a 6 mm SFA for what it's worth, yeah.
I just want to any comments from a panel, like the choice of device based on the IVUS and the angiogram?
I'm Michino Tan from Japan, and based on the IVUS findings, the classification is very limited.
Yeah,
as you said, so mainly the fibrous plaque. Yeah, so when we perform the jet stream hysterectomy, maybe there are many severe calcified lesions we target to that. So, but in this case, with a very limited calcifications, so there. How do you think?
That's what I was thinking. Because not a lot of calcium, so maybe the orbital may give you a little bit. The jet stream might give you a little bit more than the orbital. But the orbital we're not going to add you a lot of not much calcium for the orbital.
Exactly.
So maybe the jet stream is probably a good choice in this, better choice, as I was saying.
Yeah.
Maybe, but it's not a lot of calcium. Any other comment? Or just balloon, or even how about just a cutting like a scoring balloon, because there's not enough calcium. Do you think that would be reasonable instead of using a atherectomy, because there's not a lot of calcium here? Do you think it's reasonable?
Yes, it's definitely reasonable. It's just that a cutting balloon, there is a small possibility where there's a dissection and we end up with a stent. That's a possibility we have to entertain. But of course, scoring balloon reduces the possibility of that as well. So I guess it's a personal preference whether you want to accept the possibility of a bailout stent for a patient with no wounds and just rest pain. Generally, we strive very hard to achieve a leave nothing behind strategy, and therefore sometimes we're a little bit more aggressive in terms of calcium compliance, modification, and vessel preparation as well.
Okay. So you routinely use like arthrectomy for most like disease of
I think
diffuse
that between
lesions?
Kavana and myself, we have a slightly different practice. I we use arthrectomy in about 10 to 15% of my cases. I'm a little bit more IVL and cutting balloons, like you have suggested. Dr. Kavana here is a advocate for arthrectomy, so she uses arthrectomy devices a lot more in her case preparation and vessel preparation.
Yeah. I'm just thinking about the cost point of view too. So it's cheaper use a balloon than arthrectomy. But I think it's reasonable, given this sort of diffuse disease, that the arthrectomy is a reasonable choice in here.
So I think for Singapore, at least in terms of reimbursement, it's a co-payment system. So the patient's also pre-counseled beforehand in terms of device use and things like that. So it's not as bad, I guess, in terms of reimbursement. We don't have so many restrictions as well. So for us, at the end of the day, I think it's more important that the patient actually doesn't come back for a repeat intervention. And by doing everything up front, then we hope that with that, it actually reduces cost for them in the long term, sequence in that sense.
Okay. All right. We won't hold you up. Let's proceed.
Okay. All right.
Thank you.
All right.
So,
We've actually got the NAV6 filter down already in the P3. We'll show you the angio image right now.
angio pictures, please.
Yep, so that's where we've decided to park our NAV6. We measured this earlier. It comes up to about 6 mm at the P3 region. So here we go. Just deploying this. So the NAV6 has been deployed.
Yeah, fluoro.
And then we're going to start our jet stream in a short while.
I know.
Yeah, let me do the gesture.
Neil, Mag 0.
Yeah.
Come up to the CFA.
Thank you.
Ambush you.
Stop. Okay. Go. Okay, stop there. Okay. All right, so usually for jet stream, I think everybody is very familiar with the device itself. Generally, we go down two passes, one with the blades down and one with the blades up. And we go really slowly and we do a lot of racks to make sure that there's not too much emboli. So let's go. Blades down, please.
Yes.
So generally, we go about 1 cm forward, 2 cm back. We go really, really slow. We also pay a lot of attention to the sound of the jet stream itself to understand the dynamics of the calcium debulking when it crosses the lesions. When it's a little bit too high pitch, we have to slow down and come back a little bit. That's about it. So the key to this is actually to go really, really slow.
So based on the Japanese study, there are risk of destabilization based on the regional length and activation length. So there, in Japan, we in my daily practice, we selected their target lesion using the IVUS, and I applied a spot jet stream atherectomy. So maybe it reduced the risk of distal embolization. Yeah.
I think it's in Japan that you use a distal protection, or you do with it?
Not officially, so, but maybe most of the physician use their distal protection device.
But you have a technique of not using it, right? You have a technique.
Your tourniquet system.
Yeah.
So currently we use their double protection, use their filter and tourniquet system.
Oh, tourniquet.
Yeah.
Okay. I think it's very. I think it's for teaching that it's very important that you have a filter device because most of you use a lot of jet stream. You always find something at the bottom, especially the more calcified lesion. You get a lot of things, so it's very important. You have to have some sort of protection.
Can I just ask? Jun Tang here from Singapore. Can I just tell you the reason why I think you seem very surprised whether you use all these devices. Actually, one of the things that been trend is to try and reduce the amount of stenting because stenting, the stenting problems that come back so quickly. I think they're really.
I agree. I think we all
really
agree to
push
minimize
down.
stenting, but I think it's because all these devices of how to prep the lesion.
Yeah.
I think IVA is very telling. I'll give you the morphology will tell you which is the best.
Yeah.
I think this is reasonable to use jet stream. I think if you use the orbital, probably not get much bang for your buck, not much calcium here. So I'm just wondering, maybe we can get away with scoring, but there's not a lot of calcium. Probably won't get a lot of dissection. They'll probably still get away with a DCB result. I think that's probably what we're aiming for.
I was going to ask the panel actually, the floor, what are your experience using cutting and scoring balloons in the SFA or even the tibials? Because I must admit, my experience using that when I was at SGH was not great. You know, scoring the restenosis rates with scoring balloons used to come back very quickly.
I think it's more for preparation. I mean,
Oh, really?
there's not going to be a step alone. But I think with this, I think based on the amount of calcium here, I think anything will work because I think which is.
Did I hear correctly about earlier, Dr. Sogo say that in Japan you can actually use more than one device, obviously, to use like the jet stream, the smaller jet stream first, and then put up the bigger jet stream. Is that correct?
Yeah, in Japan, we can use two types of jet stream, SC and XC, two types of jet stream.
Same patient.
In the same procedure.
Of course.
Reimbursed.
Is it
Reimbursed.
Oh, wow,
course.
How do you think that's really good? I like using lots of stuff. But how do you see a benefit from using a smaller one first? Is this the embolization rates, or is it just
I think that there are two efficacy. Firstly, there reduction of the risk reduction of the perforation and the distal embolization. Because there, first we apply the smaller one. There, I think there less rate of the perforation because their calcification exists there eccentric. The bar is very close to their healthy vessel. So first, in such cases, we first apply the smaller one.
Okay.
It's a reasonable, yeah.
Is it possible to hear the sound of the jet stream from the cast?
You're basically
Is that possible?
prepping for the vessel prep.
Exactly. Yeah.
Darius?
It's so quiet, you can't hear it.
Darius,
Yes,
Kapana, hi, guys. Nice job.
Yes.
Can I just say, which size are you using? Are you using the 8 French or the 6 French device?
7.
Well, 7, sorry,
French.
7 reminds me, yeah. Is there a
French
reason why you're
Rotaract.
choosing the bigger
Rotaract.
one? Is there a
Say that
reason
again.
why? Is there a reason why you're using the bigger one?
So jet stream valve, the small catheter, the big catheters are all 7 French. The difference, you're talking about 6 and 8 French of Rotarex. There's a difference in sizing. So you may want to use the bigger ones, like the ILEX or the CFA, SFA if they're big. If you're using the Rotarex, you may consider the 8 French. Yeah, but for jet stream, it's all 7 French.
The last thing I want to ask you guys, how come you got some very good imaging using the CO2 imaging device? I could never do that down there. Did you change the settings on the machine?
A little bit. We sort of play with the images to make sure they can see it clearly.
No, we still use the AndroDroid machine, and we just inverted the images on the fluoro so that it's more visible for you guys to see that. Yeah. We're just on our second pass right now with the blades up mode and just going really slow right now. Next.
So we had a little resistance at a portion where there's a very tight stenosis, and we had the Rex back. If we can't go down with the blades up, we will probably go down with the blades down and pass that lesion and try again.
I just want to remind you if you have a some resistance for some portion, not only due to stenosis, maybe the wire bias. So you should be careful for like a long SFA atherectomy because the SFA still have some curve. So the wire will have a bias. And the just change the frontal, in the frontal have a blade. So you have a wire bias, you hear the sound is strange. You should stop because maybe you have a cut in the vessel. I just, so our expert also asked how about the sound? We did not see the sound. We did not hear the sound. So, in my practice, I will use the longer 7 French sheaths, maybe like this. If you want to do a long atherectomy, you can advance the sheath more distally and keep the wire, the bias, minimize the bias.
So as Dr. Lee said, that wire bias is very, very important when we use the Jetstream. Rotational actually, it's very important.
So I will echo the expert from Japan. You can use the smaller Jetstream first initially, because you reduce the break, the bias will be less.
Yeah, very exactly. So that after the smaller one use, the wire bias completely changed. Yeah, it's very important point. Yeah, why we apply the smaller one first? Yeah, it's a second reason. Yeah, yeah.
But actually,
more in the calcified vessels rather than just the fibrophilic plaques. Do you use it more so for double device in the calcified vessels?
Yeah, of course. Yeah.
They probably get more bias because of the calcium, so they probably.
Is it buy one get one free?
Maybe the most of the cases.
They charge you double. I don't know. Charge you double.
And next important point is their user supported wire. Yep. Yeah, high supportive wire. Yeah.
So which wire do you use?
In Japan.
Okay. Through-way.
Yeah.
But if you use the through-way, you cannot use the protection device, right?
Exactly. In such cases, we apply the tourniquet protection, tourniquet system. Do you know the tourniquet? External compression. Yeah.
But how if the vessel is so calcified that the tourniquet cannot work?
After that procedure, we apply the aspiration.
Tourniquet plus aspiration. So that's a routine.
Exactly. Yeah. So Dr. Eder performed their proximal protection, make a reversal flow. It's reasonable.
So because we don't have any experience using the wire other than Abbott's wire, so I don't know what's the difference between them. Can you share with us? What's the difference using the wire through your wire and the wire from Abbott? I mean the wire.
Wire?
What's the difference when you're using the wire from Abbott, the Navisys wire or the through?
Yeah. I think one of the problem of the filter wires are wire support is weak. Yeah. Compared with the slow wire. Yeah. So we have to apply the more effective wire bias. We apply the slow way. So that if it's needed, if don't need it, we apply the filter wire. Yeah.
Okay, I can let you keep going. We're probably going to switch to the next room first, and then we'll come back to you. Is that okay? Singapore?
Yeah. Okay.
All right.
Yep,
Thank you.
Room 2.
Mute our mics, please.
So please change to the room 2.
Hello, room 2. You're live right now.
Okay. I know. Okay. Hi, Brian.
Hi.
Good morning. Yeah.
Oh, Kevin.
Yeah.
Oh, hi, Kevin.
So let me Yeah, hello. Let me introduce my very special team, and it's Dr. Lin Zijie and Dr. Chen Peirong, and another is our very important assistant, because I forget to bring my assistant here. It's the boss of IVL, because he know how to prepare the balloon, which is extremely important for the performance of IVL. I think it's rare to bring the boss to the lab demonstration.
But not everybody like you can bring the boss here. So
So maybe we can
Kevin, you are the
introduce
boss.
tell us
case.
the case. Yeah.
66-year-old man Mr.
Yeah.
Wang, with a complex medical history including hypertension,
4点零
diabetes, hyperlipidemia, CAD staple stenting, and ESRD. He has bilateral PLOD and previously underwent a left below-knee amputation in 2023 at an outside facility. Most recently, on September 26, 2025, he received endovascular therapy with bare metal stent placed in the right SFA and the right external iliac artery. This video is the angiography of left lower extremity during that procedure, which revealed diffuse severe calcification in the left SFA, and the patient also presents with some ischemic signs and symptoms in the left leg. Today, operator may consider IVL as a component of the procedure to effectively manage the severe calcification.
这里好，go distal. Yes, and let me show you the original angio first. Let's start from series 2. Right? You can see there is a left iliac lesion there. We did not show you the lateral view, but the pressure gradient is 40 millimeter mercuries. We will handle that lesion later. And next. The main target is here, SFA diffuse lesion. And next.
Can I get it right, Kevin? He had already a below-knee amputation on the left.
Yeah.
And we're treating the left.
Yes,
right?
yes. I know. What do you think? Yes.
What do you think? I don't know. We're asking what do we think?
Astonished. Surprised. And next. Okay. It's a popliteal and BTK. And next. Yeah, it's already have a BTK condition.
Yes.
But of course, usually if the patient have still poor wound healing over the left knee, there is of course, have an indication, strong indication for TPA.
It's a okay.
Hi, Kevin. This is Janu from South Korea.
It doesn't.
Can you hear me?
Yep.
Yeah. So
yeah, I can.
I think we have a couple of people on the panel just wondering why you are treating this patient, because obviously this patient isn't a claudicant. So if the patient has a non-healing stump or other reason for this intervention?
Yes, you know, there is a very strong reason in lab demonstration is that it's difficult to find a suitable case sometimes.
I hope
so
your balloon
for
is
this
free.
case, maybe, we just demo. I think the purpose of this case is because many hospitals in Taiwan, it doesn't start to use IVL, so it just showed this technique and how we prepared the lesion and what thing we should notice about it. Yeah. So about the indication, there's in fact no indication for this case, honestly. But when I see the file of this case, did not refuse. Of course, if they have a better choice, I like to demonstrate other case. But sometimes it's difficult to find a suitable case. I'm sorry for that. Yeah.
All right. Okay.
Let's presume he still have the left leg. Then let's continue the discussion.
Okay. We can discuss over dinner.
Yeah. So any comment from the floor? So because we also perform the IVUS, so you want to
Please,
discuss first
obviously,
or see
it's
the
very
IVUS?
diffuse, very severely calcified, and I can see, we need the different options that can be used to prep the lesion. So any comment from the, you want to see the IVUS first? Let's see the IVUS first, and then we have a bit of a panel discussion of the choice of devices.
Okay, then show IVUS. It's from proximal to distal. Okay. So can you see
I
the
think considering their patient
IVUS now?
status, the poor vascular weight, and after the major amputation, I think their apply over their atherectomy system is a very real risk for their distal embolization and may lead to their miserable result. So I apply their laryngoplasty and IVL and so on. How do you think about that?
I agree.
IVL is I think reasonable for
Yeah.
such kind of patient,
Okay.
considering the distal embolization.
Yeah. Because the distal runoff is very poor, already
That's right.
BTK.
Exactly, yeah.
So we have to avoid just train
Mhm.
a surgery like
Exactly,
this.
yeah.
But if we want to do IVL,
Mhm.
the balloon size is big, so we have to consider whether this balloon can be cause all the calcified lesion. So maybe if IVL balloon could not be passed, we can use rota aberration. Because rota aberration, the particle is very small, less than RBC size, so we don't have to use filter to protect distal protection. So if I think Dr. Kevin have a very much experience for this kind of calcified case, so we can see the IVUS and to decide our strategy.
Yes, as you see, you all see the IVUS?
Not completely. Can we run the IVUS and maybe?
Can you repeat again?
Can you see the IVUS image?
Yeah, we can see the image. Is it
from
proximal to
common
distal,
femoral.
is it? Or?
Yeah, proximal to distal.
Okay.
And
Distal
where
to
is it
proximal.
now? No. 哎，你放到哪边了？从头开始。We start from a common femoral artery. This is a proximal SFA. So you can see the concentric calcification, and the vessel size is about 5 to 6 millimeter. And yeah, so very diffuse lesion. So
Very deep calcium.
so yeah.
And most
So so any comments from the moderator panel and audience?
Hi, Kevin. This is Guangming from Hong Kong. I think this is a good choice for shockwave, just for discussion's sake, because the calcium is very dense and also thick, also involving the media as well. So for media calcium, usually the surface atherectomy devices like Jetstream is not going to reach that well. Shockwave, on the other hand, reach those medial calcium much better, and it will crack those medial calcium. So I think this is a good choice of device in this case.
Is the long-term parents rate okay if the distal runoff is poor and using the IVL?
I don't think it really matters. It's just really just cracking the calcium, just preparing it, so it won't cause.
So I think IVL works in a total different kind of way than the atherectomy. It doesn't shave off anything. It's a more powerful balloon.
But you
more
open the
powerful
lumen up, but without the good distal runoff, it will cause more thrombus, right?
Same as balloon angioplasty. So if you have some runoff distally, then the balloon angioplasty can.
So you could tolerate, it means that the IVL can tolerate the poor distal runoff, because we don't have any experience about the IVL, actually.
It's just a balloon. It's just like a balloon. It's just a balloon. It doesn't matter the runoff.
Okay.
I think for the case of this case, I think it's just talking about the calcium because we don't really have no
哎
runoff.
这个我们
regardless.
子杰，我们这个已经 inflate 完了嘛哈？对，那就出来。
I'm
I think
Dr.
the
Xue.
based on the IVUS findings that are concentric and a
okay.
medial calcification,
Yes.
a good indication of the IVL.
Exactly, yeah. The deep
That's
calcium,
it.
which have said,
Yeah.
like Kwame says, the jet stream or the other atherectomy may not reach it. So I think for this deep calcium, concentric, I think IVL, properly sized IVL will give you the best.
Yeah,
So
yeah.
sizing of the IVL is very important based on the vessel. So it's very important to use the IVL. So you don't
Exactly, yeah.
undersize using very small IVL, which you're not going to get contact and get the effect.
But I would anticipate some difficulty in passing the IVL down because the
They're a bit bulky.
M5 or depends on what IVL you're using.
It would be M5.
If you're using M5, it's probably going to need some pre-dilatation with maybe a 203 balloons before you can get the IVL down because it's very like stenotic lesions all along.
A9 heparin 在5000呢。
And for this
这是5天
amputated
把它
leg,
整
I
头
think
掉。
there is no good
think
runoff,
that
so we
there's a one
will
to predilate
prevent
of
long
4
standing
millimeter.
and at the end of vessel preparation, because if we give long standing, there is no runoff, the restenosis rate may be high, so DCB will be better. But I don't know if IVL can decrease the possibility of dissection and standing, or will be and what the size will be better because according to EM with optimal size of IVL, maybe the chance of dissection will be higher, and I don't know if any other choice to decrease the possibility of dissection.
I mean, the trials do say from the structural trials that the dissection rate is lower with the IVL. So that's the whole point.
Brian, do you have to be true lumen actually with these balloons?
You don't.
Because there's the risk of aneurysm formation later on, or is there any issue
With IVL or no?
Yeah, IVL later
itself,
on,
no.
and after you drug it afterwards as well. Is there any issues with that at all?
Not that. I think the study they've shown not that we're aware of. You don't have to be. Not like the other device where you're supposed to be intralumen, but for the IVL you don't. But you may not get the bang for your buck. But I will show you my talk later, which I intentionally go.
And in terms of sizing for the audience, for them
Yes.
who are learning how to use
One-to-one.
this, it's one-to-one.
One-to-one.
Okay.
Or even slightly over line one, it's okay. So at least 1-to-1.
Just say you want to be a bit more thrifty with your balloons, okay, and just say the lesions goes all the way down from the fem-pop into the TB trunk. Can you use the same balloon, or do you have to try and use different balloons because they're very expensive for what they are?
Yes, it's off-label, but you can go up a little bit high if you to get a bit more gain. Yeah.
Low pressure balloon, so we can't really go high pressure with the IVL. And also you need to have a good vessel wall contact for the shockwave to work. If you use a very small balloon in a very big artery, then probably it's not going to deliver the shockwave energy that effectively.
Yeah. Using two balloons here to pre-dilate and then go in again.
We don't have screen.
So Kevin, can you want to proceed with your so you've obviously chosen, you've crossed the wire, right? You crossed the lesion.
So here I want to, as the moderator and the panel, we have two strategies. First is just go on with IVL 6 millimeter and to demonstrate it. And the second strategy is just full dilate the lesion, and then we choose those who cannot be dilated to do the IVL. So which strategy will you prefer?
Well, we worry that you probably can't get your 6 millimeter IVL across this lesion because they're a bit more bulky, so they're difficult to cross because I see very severe calcification, very tight. You can try and demonstrate that you can't get across, but if that's the case, then you're asking is, do we do a small balloon to facilitate the IVL, or just to do a standard balloon angioplasty and then sort of like a bailout? So I think the option is probably the best is to do a small balloon. Try to cross it with the IVL of 6. Pretty sure you can't. Use a small balloon and then use IVL to get the benefit. And try to minimize dissection. If they said, if you just use a normal balloon, then you're probably going to dissect it all the way.
The strategy one is excellent, but just worry about sometimes balloon rupture after maybe 200 shots or more. Then we have to use another one. It's a little bit expensive. And then for strategy two is just we fully dilate the lesion and so only choose those segmental undilatable lesion to demonstrate the effect. So now we are, in fact, we pre-dilate the lesion with 2 millimeter balloon. So now we are going to use IVL, and how to prepare it is very important. Yeah. So it's a very.
Kevin, can we Kevin, can we pause 1 second? We just go to room 1 briefly, and we'll come back to you. Is it okay?
Okay.
So I don't okay. So can we go to room 1, please? Room 1, you're online. Room 1.
Oh, Brian.
Hi.
Can you hear?
Oh, hi. How are you?
This is Osama.
Osama, how are you?
Very nice. Great. Long time no see.
Okay. Well, you want to?
This is a very interesting case. Okay. Yes.
Tell us about your case.
Can we start at the case presentation first?
This patient is a 65-year-old male, Mr. Xiong, with a history of buccal cancer stage post-operation and CAD stage post-PCI. He also suffered from bilateral peripheral artery disease. In June 2025, he received 2 bare metal stents placed from the right proximal to the mid SFA and a superior stent in the right distal SFA to the popliteal artery, along with balloon angioplasty of the right peroneal artery. Angiography also reveals a CTO at the orifice of the right anterior tibial and posterior tibial artery. Video on the right side show distal roundout of right ATA and PTA. And this is the final angiography of left right leg EVT. Operator may consider a retrograde approach in today's procedure to successfully tackle this challenging CTO.
So
okay, Brian. So
is the indication for is critical ischemia here, or is it right? It's got a
yes, but the patient, had no tissue loss, no gangrene, just a rest pain.
Rest pain, okay.
Rest pain, residual rest pain after revascularization for SF and the popliteal region. So as you can see, the previous angio shows a good runoff on the below the ankle. We can have a good dorsal patelis artery and the plantar artery after recanalization of the SFA region. So can we share today's angio?
Is that today's angio?
I expected the revascularization for AT on the posterior tibial artery. But I think the angio is completely different from the previous angio.
Yeah,
as you can see here, yes, after injection of heparin, 5,000 heparin, we cannot detect it below the ankle condition.
Yes.
And we also checked the below the ankle using the DSA. And we have a very slow flow condition. Surprisingly, no dorsal patelis artery. That's a big difference from the previous angio. So that's why I'm planning to perform the AT revascularization thanks to the dorsal patelis artery retrograde approach. But I think the no dorsal patelis artery, no below the ankle runoff, especially focusing the AT. So that's why we should change the treatment strategy for fixing the just the proximal region because the patient condition the less pain. And we also check the angio from the SFA to popliteal artery. So previous stent is very expanded, but I think the moderate stenosis at the middle part of SFA. So what should I do next? That's, I think, the discussion point.
Any comment from the panel?
Ida sensei, Tan speaking this or the considering their patient status, one of the options is a medication or in treatment of their of the knee region.
Yes,
so of
yes.
course, yeah,
Thank
yeah,
you.
yeah.
Is there a lesion there at the TP trunk that potentially maybe can
Yes,
improve?
yeah, Brian, you are, Brian, you are nice. So I think that we detected moderate to severe stenosis of the tibial parent trunk. So that's why I selected the peroneal revascularization, and I've also checked in the vessel condition using the IVUS. And we have a very significant stenosis of tibial parent trunk. So we are discussing with my colleague here. So we have a significant stenosis tibial parent trunk. So we decide to perform only the proximal fixation. Here, I checked in the normal healthy running position using the cutting balloon. So I decided to perform the cutting balloon treatment for tibial parent trunk. Under the IVUS evaluation, I used the 4 mm balloon catheter. This is an angio after angioplasty for tibial parent trunk. Much better.
Much better. And the flow
Yes,
seems
I
better.
also checked the flow speed. So, so what do you think? So 6 months before, so we performed this stenting for SFA to popliteal segment. But below the ankle, below the knee, and below the knee and below the ankle conditions is completely different from the 6 months before.
Yeah.
Yeah.
It might be due to the thrombotic problem. I expect. So that's why. So the patient condition is just rest pain, no tissue loss. We will finish this procedure just recanalization of the tibial parent trunk, based on the guideline and also my experience. Brian, what do you think at this point?
I think a good idea. Are you going to finish with a DCB?
DCB.
Sorry,
What
Professor
type of
Rita.
DCB?
Professor Rita,
Hi.
I have a different opinion for this case because we can see the distal run off is very slowly. Maybe how about put the catheter into the posterior tibial artery and do selective angiography, because the distal flow is very slowly, is different from previous angiography. Maybe some thrombosis or other lesion for this kind of lesion, because I think
Yes.
maybe the patient have a pain, maybe due to the local thrombus dislodge, maybe. I think maybe we
So,
can put a catheter to the posterior tibial artery and give some NTG vasodilate here and see the response, the posterior tibial artery flow. How about this strategy?
I don't think so, because yes, posterior tibial artery and the plantar artery was intact by initial angio. Maybe some microthrombus and spasm was the main cause for this situation, but it's very challenging to treat endovascularly that this kind of the below the ankle condition. That's why I think that we should finish the BLISS procedure just only the proximal revascularization. So because I'm always facing the below the ankle condition in the CATI treatment, but it's very challenging for recanalization only the just capable device for below the ankle treatment. So that's why I think the proximal revascularization is good enough for patient symptom improvement.
I
But
totally
anyway,
agree.
thank you very much
yeah,
for your
yeah,
comment.
Yeah, I totally agree with Dr. Yi there. So there, after this procedure, I applied the antithrombotic therapy for this patient and watch.
Yeah.
Yeah.
I agree. I think
And,
Dr. Lee's
yes,
comment was whether
yes,
you would just
Brian.
put some nitroglycerin down the procedure to maybe to see it a bit better, but it's not intervention. Just doing selective angiography
Yeah,
of
just
the
a temporary, yeah.
or
yes.
some nitro, maybe
But I
some
think-
spasm, maybe something that reduces the distal flow. I don't know, but not intervention. I agree.
Not intervention. But you can see here that this angio shows a very good condition of the proximal side, thanks to the TPT recanalization.
Yeah. I think.
So maybe, it's good enough for patient's improvement here.
I agree. Yep. It's improved the flow
Okay,
already. So I think
I'll
it's
finish my
reasonable.
procedure. Okay.
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 Thank you. Brian,
thank you.
Thank you.
See you later.
All right. So we can go back to room 2.
Arigato.
All right, Kevin, you're back on.
Yeah. Okay. We just after pre-dilatation and
With a 2 millimeter balloon, is that right?
With 2.5 millimeter balloon.
Okay.
And now we are taking angiography, and we choose the 6 millimeter IVL, and it's already ready. Yeah.
Okay, he's got a little bit of lumen gain, not much dissection.
Yeah.
So, okay. So you say you're going to show us something before. You're going to show us how you prep the IVL. Is that right?
Oh, it's when you stop the video at that moment. During that moment, we prepare the IVL. Sorry. So just clean the bubble as possible as you can, and do not let any bubble in the injector. Yeah. So can you see? Show us the from the SFA. Yeah, Proxima seemed okay. 下一个。Yeah, it's diffuse, calcified, and yeah, next. Yeah, okay, next. Okay, so maybe we will start from the 40 centimeter, 40 millimeter.
What's the diameter of the
T2
vessel
area
at
to
40? Is it 6? I worry if you put a 6 millimeter IVL.
around 5 millimeter.
Yeah.
Proxima 6 and the popliteal just around 5.
I think that the question here was the panel before. Would you use the same balloon or use a 2 different size balloon? Are you happy with putting a 6 millimeter IVL in a 5 millimeter vessel? Are you?
So your question is...
The question I think the
that one
panel
is
asking whether
want
you
to
can
buy-
save money and put the same 6 millimeter balloon down to the pop, which is 5 millimeter.
Yeah.
Or you want to use 2 different sizes.
I think 5 millimeter is okay.
Okay.
We just use 6 millimeter IVL. Yeah. Okay. The balloon will go in.
And yours is a 6 by 6, right?
Yep.
Kevin, it's a 6 by 6, right? So
Yes,
it's a
yes,
long
yes,
vessel,
yes.
so mindful that you don't burn all the pulses. You might need may not be enough pulses for such a long lesion from 42.
Joseph here
Yeah,
from Singapore.
so-
Just a practical question. You know, we're all limited by the pulses, and we are going to start the
Yes.
treatment from proximal SFA all the way to
I'm
popliteal.
worried that you run out of pulses.
Precisely. So would you start off at the proximal SFA first, and then slowly make a way down?
But the problem doing that is that if you pulse it and then you may not get the balloon further down. Once it's dilated,
Yeah,
the
yeah.
crossing profile is low. So I would probably start with with 6 millimeter.
The
and go-
adductor canal.
Yeah,
so-
exactly.
yeah,
That's
yeah.
bang for your buck. Go for adductor and
Yeah.
go all the way up.
Because I mean, the IFU says that you got to be like 10% oversized for your balloon, And ideally, in this situation, it would be like a
okay.
5.5 IVL for the
Approximately 1, 2
popliteal.
from
And if money is not the
okay.
problem, then a second IVL for the SFA.
But I got to tell you, there's a lot of IVL companies, and they have some of them have unlimited pulses. Okay, you can talk to the company. They can jailbreak the system. I'm sure you can do more. But
I mean, interestingly, for this company, you know, the
嗯
cardiology
一
IVL
个
pulses
重
are
的东
much
西啊也是
lower
OK
than for the peripherals. And then, you know, I always ask them, why is it different?
they want you to buy more balloons.
Okay, so you advise us to do a shockwave from the proximal portion,
Well,
right?
I wouldn't. I would probably go distal, probably from the ductal canal up. Because once you open up the balloon on top, you may not able to get it. The clotting profile is much worse. You probably kind of get it down.
Yeah, we do
yes.
from a popliteal. Yeah. Where's the one? What distal 看一下。
He's struggling already.
Yeah, here.
Actually, there in Japan, a clinical trial has been just, finished. So I think their profile of the bottom one is not good. Considering available.
Not good.
So
but there are other companies which are shockwave crossing profile better.
Yeah,
so
yeah.
That can
最
be
后一
done.
个，我跑一下。
So you have to deliver there as far as much. Far. Yeah. Distal
Okay,
to
how?
proximal.
Exactly.
Yeah.
Yeah.
就
So you got to be mindful of the pulses, because sometimes you need to do multiple applications in the same spot, you know, to get the outcome. It's not just one off. So you sometimes you can run out of pulses.
And I guess the other practical question is, you know, the IFU says start with 4 and then pulse it and then go up to 6. How often do people on the panel do you go up to 6 and then pulse it up to 8?
The 4 is only to position, not reached by it. So you really have a low pressure just to get the balloon to really oppose the calcium. So if it runs with low pressure, that's why you need to size the balloon properly. Because, okay, so you can, other way of doing it is using a small balloon and go up 6 to get the position. Yeah. But, you know, if you were to 1-to-1 or a little bit more, then use 4 to position, and then, you know, the 6 is really just to show that you can expand, that's all really. Not really using it as a balloon angioplasty balloon.
Yeah.
For BTK as opposed to the FemPop using these balloons? Because my experience going BTK with this is that the gentleman just said the profile is so big, it's almost impossible to cross it.
But BTK is different. Use a S4.
Yeah.
S4 is slightly a better profile and a bit longer in length. So it's still accurate. Yes. They're not the most crossable balloons.
Suction.
So you go up to 4 now, right, Kevin?
Yeah. Yeah. We. Yeah. 好。
要转到细哦，对对，有转的。
We have some air bubbles inside, so we need to evacuate a bubble first. Inflating them. I'll check the balloon. 看有没有 bubble. To form atmosphere is okay. Inflate.
Four.
All right.
4.
Okay.
Okay,
So you can
we
see the
add
balloon.
to,
You can see all the calcium
atmosphere.
impeding. Are you shocking now? No.
Yeah.
All right. Can you keep this fluoro on? Yeah. So you can see. Hopefully, if it works, then you can see the balloon expand after calcium cracks.
Yeah.
That's the theory. Is it applying now?
Yeah.
Click, 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 click. We'll
Yeah,
make the sound for you.
yeah.
Click, click, click. Okay.
Yes. Okay. The first.
Stop.
Okay. Go up to 6.
Okay.
Whoa.
Oh,
Oh, hey, we blacked out. We can't see anything. Oh,
Okay, come.
Can you come back? So show us. This is a 6 millimeter, right? 6, right? Okay.
Yes, yes. And
Okay.
we do a second deflect.
So also interesting of the pulse, even though there are 5 nodes, the most of the bang for is in the middle. So if it's really heavy calcifier, you want to put the calcium right in the middle of the balloon because it seems to the concentration of.
We do the second round.
Not enough. Not enough pulse. Not enough pulse.
Not enough pulse.
All the way. So I mean, question: 4 and then pulse and up to 6, and you still see a wasting. Would you now then do a 6 and then pulse to go up to an 8?
I would move my note exactly where where you're not gonna. You probably have a point in it. So move the middle one, probably get the most pulse.
Yep.
Right there and then pulse it, right.
We move to the next target because we only have 240 shots.
All right. So after a few pulses, we might go to the lecture,
cool.
and then we'll get back to you. Okay. All right. You can see again, this is the calcium restricting the.
Okay.
So you pulse it.
You see the proxima. Yeah. You see enlarging.
You can see a little air bubble in your balloon going a bit crazy.
Yeah. Yes. It's the bubble. Okay. The evacuate bubble.
Excuse me, just a small question. Dr. Kevin, are you satisfied about the balloon expansion in the popliteal artery? Because I see still a little not
residual
over under expansion, a little under expansion. Do you satisfy?
In fact, not satisfied. And however, if I continue to do this area, maybe I'll need. In fact, before the operation,
it's okay. Both is there. Both is there.
But sometimes you may not get everything perfectly. I think if it cracks the calcium, then if you do IVUS, it's all correct. Then you can use another balloon angioplasty. You can probably get the result in a lower pressure. I think.
He's using a 6 for the 5 millimeter pop, so I don't think he will go too high a pressure in the popliteal with this balloon.
Yeah.
He probably might need another 5 balloons.
That's what I'm saying, using since we need a lot of pulses, so I might as well use a 5 and then a 6.
OK， 这样不行。
OK。
好，那你把那个空气的排掉。没 air 了嘛
Dr. Kevin, because we have a mini lecture, so we will come back to see the result, and so
adjustment.
It's okay.
Yeah. You can see the 28 millimeter, and now it's fully open. Yeah, just after the shock wave.
Yeah. So
okay. See you later.
So at this moment, how do you feel? Just remove the IVL or just give more pulse here?
Maybe we'll continue for, but we have 210. So maybe we'll have one more round here and move to more proximal portion. Okay, different. Okay. Time it up. Oh my God.
So.
Okay. So I think that the main session, the theme here obviously is calcium. So I've been talking about IVL evidence and some experience. I think IVL has been around for most countries around here, so I won't labor too much about all the data. I'll show you something what's new that's coming up. So we've talked about calcium's really still a challenge. We saw the cases before. You can cause dissection, perforation, recoil, and all these things that make us difficult. And all of devices we have all are not perfect. All these different devices, all atherectomy devices, even IVL, they're not perfect. And particularly for the surface device like Jetstream, Hawk or the Orbital, they don't deal very well with the deep and medial calcium. As you can see in Kevin's case, most of his problem is deep calcium rather than more superficial calcium. So that's where IVL potentially has a better advantage here, which using a shockwave which can treat both superficial and deep calcium. And also in the trials, it shows to be a little less lower risk of vessel injury, less debris, and then therefore no need for a protection device compared to like Jetstream or orbital atherectomy. Okay, so this broad application, I won't go into much detail. Obviously, it has been used different the sizes of the shockwave or different types of IVL, per se, different companies, has been shown to be effective in from the iliac, SFA, below the knee, using different sizes, and also in even other, or in the coronary, obviously, that's where, because of cardiologists, we used to do that a lot. And as I mentioned, it was supposed to work well in concentric, but in our experience, or I think most people experience, it works best with concentric calcium. In eccentric calcium, they say it works, but in my experience, they don't work very well, okay? And also, it doesn't work very well with nodular calcification either, okay? For those nodular, eccentric, potentially, I think the atherectomy may be better for those, but this is what, but I do agree that superficial and deep calcium are useful for IVL. So I can go back one more, sorry. In terms of strategy, I think most of us would use it mainly as a vessel prep rather than using a standalone therapy, so using it as a prep in view to potentially a DCB. So this is really, the data is not that new. These are from the Disrupt trials. It showed that it works very well across the board in SFA and POP and infrapopliteal arteries with very minimal complication rate. So it's one benefit of IVL is that it's very low complication rate, and it's sort of effective in terms of modifying calcium. So you can see that just IVL alone can give you a fairly good luminal gain compared to a final. So I guess that's what they say potentially can use as standalone therapy, but I think most of us in SFA probably will finish with a DCB. And then again for BTK, again it's a similar result, very low complication rate, very safe, and again get a very similar sort of standalone result, which shows that it's very good for vessel prepping. So these are nothing that's new. What's actually I think more exciting new, which is presented at Viva in 2024, is the Javelin, which is the forward-facing IVL, which unfortunately I don't have experience with because I've been talking to the company since then for last year, but they're still reluctant to lick it out of to the country of America. So what's different is that if you have a calcium wire cross and you can't cross the balloon, the IVL itself doesn't work very well. I can't play the video. Can I play the video? Can someone click on the video? Because I can't click. Okay, so if you use a standard IVL, it doesn't work because it's just behind. So what they've done is using a front-forward facing IVL, which is a emitter going in front, to help crossing. So I think nowadays, often we find that we cross the wire, we can't cross any balloon. Even with the 014 wire, we can use coronary balloon 075, 085, you can't cross. And the other option using a laser or using other like forward-facing sort of device, but I think IVL, forward-facing, may be an option for these cases where you have a wire cross, so you can cross with the balloon. So this was presented at Viva 2024. There was the IDE trial, which showed with 90 patients, about 100 lesions, and these are patients with a lot of calcification, obviously very complicated patients like diabetes, renal failure, and you can see here most of 95% of them have moderate severe calcium, and a lot of these patients, 40% up to 40% have CTOs, and half of them are BTKs. So these are lesions we sometimes find that it's difficult to cross, to treat, and then basically they're able to demonstrate that using the forward-facing IVL that has a very low, at least a very low no need for a digital embolic device. And you can see that again, similar to the other IVL, have very low complication rate in terms of dissection, distal embolization, and no reflow, and as very little major adverse event. And the key thing is that actually they're able to use this device to cross most of the lesion, but 90% of the lesion can be crossed after wire cross with this IVL. And then you can, again, similar to other device with IVL, is that after you can get a reasonable luminal gain, but probably not as good as a standard IVL because it only go forward facing. But again, you can see it can stepwise get an improvement of the luminal gain after pulsation and then final. So again, this is a good a way of forward prepping a lesion that it can difficult to cross. So this is just a demonstration of sort of like a lesion that you can get with a forward-facing IVL in a very small vessel. So the Javelin, I think, is very exciting. I was excited about it. So because we oftentimes that we see lesions again and again that we just wire cross but can't cross with any devices. Potentially, this could be if it's effective as a claim of crossing 93% and in very heavily calcified lesion, then there could be something additional to what we have now. So this will be something that I hope that will be bringing it across to Asia. So next about little evidence of basically using a different way of using lithotripsy. So this is recently we reported this case using intentional intraplaque lithotripsy in the way of treating very eccentric calcium. So as mentioned before, IVL doesn't work very well with eccentric calcium, and therefore we've got a way of converting eccentric calcium to a concentric calcium so the IVL may work. So this is so intentional is basically using in a combination of 3D wiring technique, intentionally go subintimal behind the calcium and the re-entry back into the true lumen, and then passing a IVL intraplaque to give maximal gain. So converting a eccentric situation into concentric configuration. I think this is a technique has been obviously performed in Japan. I think this Acadia, this is why I call Acadia shock, because this is Acadia with shock rather than Acadia with the jet stream. So in Japan, they're using this with a standard balloon, also with a jet stream. But again, the limitation of the jet stream is obviously embolization. So I've basically tried to use IVL potentially to minimize that. So just to show you a case we have, this is a 64-year-old gentleman with bilateral collocation. Previously have DCB bilaterally, so basically come back again with his failing standard balloonoplasty in DCB. A typical patient, type 2 diabetes and stage renal failure, so very healthy calcified patient. So he's got bilateral collocation. So we fixed the left first, stage first, principally easier, simply more focal stenosis in the distal SFA. You can see a very eccentric calcium distally. So our aim is to intentionally go behind the calcium. So I'll go a little bit faster for you. So you can see here that we've got two wires. One wire is intraluminal, and then with the IVUS on the intraluminal to confirm that the other wire is actually intraluminal. You can see that using a very stiff wire, XS40 or 014, they can see we do a tunnel behind the calcium and re-enter distally, and that's confirmed on IVUS. You can see the separation of the two wires. So we also confirm that the wire is indeed intraplaque. So for this case, we also put a distal pressure device. So you can see here that there's a IVUS of the intraplaque IVUS versus the intraluminal plaque. So you can see in the intraluminal is a very eccentric calcium, and you can see in the intraplaque we actually indeed got the Y into the plaque. And then we also have a filter. This is a Spider RX, and then we use a shockwave intraplaque. So after the shock, we can see there's some luminal gain. Unfortunately, this is the first time we've tried that we use a IVL, which is a bit too small. Ideally, we'll probably use a 5 or a 6, but this time we only used a 4. So the gain is not as great. But still, we're able to supplement that with the angioscope and also with the sheet and high pressure balloon with minimal dissection, and then we'll finish the DCB. And this is the outcome at the end. You can see here that there's a quite significant luminal gain with no dissection, with very minimal debris retrieved. So this was on the left leg. So then we brought the case back for the right. And this is for those who remember, we did the case as a live case in JET early this year. So this is really truly essential calcium. You can see here that will be difficult to treat with most devices. It's a sort of proximal essential calcium here. So again, intention is to do intraplaque wiring and then do intraplaque lithotripsy. And also put a Spider RX distally as a backup. So you can see in the luminal IVUS, you can see here, you can see it's essential calcium. And then you can see here, further up, very focal essential calcium here, okay? So potentially, I guess you can use just IVL up front. It may give you the bang for the buck, but we decided to try to do intraplaque wiring and then use intraplaque lithotripsy. So here, we intentionally can see the intentional intraplaque wiring. You can see the wire separation of the two wires. And then we also confirm that with a intraplaque IV. You can see here, right here, you can see that this bit is the intraplaque, where there's the wire indeed is intraplaque. So again, this time we were able to use a much bigger 7mm shockwave size to the vessel. So you can see here as the IVL expand, you can see a very good expansion with a properly sized IVL intraplaque. Okay, so this is the post-IVL. You can see here, the gain is quite significant intraplaque, just balloon. Mindful, this is a lesion which already failed previously standard balloon and DCB. So you can hear, you can see quite a significant luminal gain from the IVL standalone. So here, then we finished it off with a DCB, 7mm DCB, and this is the final result. And this time we have no debris in the filter. So patient only have 1 month depth, and the patient's collection free up to now it's almost 6 months. So it's very brief. In summary, there's still calcium still remain a challenge for us. I think we have many devices on the market. I think IVL is just one option if you have to, but for the right lesion, I think it works well. At least we know it's safe in most of the lesion, and it can, the main advantage reduces distal embolization. And the particular shockwave has been shown to have good evidence from the trials to have low residual stenosis across different vessel beds from ILEC down to BTK by disrupting both superficial and deep calcium. And I think what's coming up, the Javelin may be a useful novel tool for us to tackle uncrossable calcified lesion in very narrow small vessels. And then so our intent is to actually borrow, obviously with the Japanese technique of Arcadia wiring, is applying the shock plus Arcadia as Arcadia shock. Could be a novel method to treat a very eccentric calcified plaque. So with that, thank you.
Thank you. Thank you very much. Very excellent speech. Is there any question from our expert?
Yeah, thank you for your fascinating presentation, Brian. So I totally agree with your intra-calcified plaque wiring. Yeah. So how do you differentiate after the intraplaque wiring, which device you choose, IVL or Jetstream and so on?
Okay.
After the intraplaque wiring.
We use just the IVL because of potential risk of low risk of distal embolization. Yeah. So I don't know which is better. I know the Japanese, obviously, you guys have more experience using, the intraplaque and then using the IVL.
Based on the risk of the distal embolization and the patient background and so on.
Yeah.
Thank you. Yeah.
Hi, thanks, Brian, for that great talk. I was also going to ask the same question, similar question. If you had a very superficial nodular lesion like that one, how would you choose, say, IVL over something like a Hawk 1, where you can direct the blade against the surface?
My experience with Hawk 1 is sometimes with this very eccentric calcium, when you start, it's not that direction as you think, and you usually end up digging around the calcium, and so you end up getting like digging around a rock in the sand, and then you're guessing, massive, aneurysmal dissection. That's my experience. It's difficult to get the Hawk personally to dig into the calcium. So I guess the other option is orbital. Orbital works for these, for eccentric calcium. If you're patient enough, it works. I think Jetstream also works. But again, I'm not sure it have a high risk of the bias with the Jetstream causing more injury. I'm not sure. I'm not a very experienced Jetstream user. So do you find that Jetstream works for these eccentric calcium? Eccentric.
Eccentric.
Yeah.
Eccentric.
Yeah.
I think eccentric.
Yeah.
It's very effective.
For Jetstream.
Yeah.
So.
Just a question about the intraplate closing. In my experience, some cases have a membrane in the central of a lumen. If you through the second wire through the intraplate, and you did just angioplasty, and the IVUS will see the membrane in the lumen. But actually, the lumen size is gain a lot, but have a membrane in the vessel, in the central vessel. How about if you face this situation? How about, do you see this membrane in the central vessel will influence the clinical outcome? Or
I don't know. Maybe I don't have done.
Just like you show the second case, you can see the IVUS have a membrane in the central vessel, because you use two lumen to dilate the vessel.
No, just only balloon through the intraplaque.
Yeah.
I didn't balloon on the intralumen.
So you have a two channel.
Yeah.
Go into the distal vessel.
After the shock, because you just crack the calcium, it just.
Sometimes I think sometimes the two canal have a connection.
Yeah,
but
maybe.
Sometimes they cannot connect. So
I agree. If you don't connect, I think it can possible. I think it only maybe work if it's just one lot of calcium, which is not too long, and just one eccentric calcium. I find these eccentric calcium focal calcium very hard to treat. If it's diffuse, I think maybe even easier than these really focal huge eccentric calcium.
Yes.
It's just
Is there any question?
Okay, thanks, Brian. And so, should we go? Oh, so we go back to Singapore.
Singapore. Sorry, we had to go to 2 other cases, and then now we're back to you. Oh, yeah. Singapore, can you hear us? Singapore, can you hear us?
Hi, I can hear you now.
Oh, good. Sorry, we took a while to get back because we went through 2 other cases. Now we're back to you. So can you just update us about your progress, please?
Okay, so we stopped at the Jetstream, and then we can show you what we have after Jetstream. Can you show sequence 30? So right after the Jetstream, we had a perforation at the proximal SFA. And then that was tamponada with a 4 mm Sterling with about 3 minutes, and that has resolved. And then subsequently, the post-Jetstream scans angio was reasonable. And then we POBA with a Sterling 6 mm. And then subsequently, the results was reasonable, and we proceeded with a paclitaxel balloon ranger. Let me show you the perforated sequences. So this is right after we Jetstreamed. The perforation site was right at the origin of the SFA. We then tamponada with a 4 mm Sterling. And can you show the next one? So this is right after tamponading with a 4 mm Sterling, and the perforation has resolved. And this is a post-Jetstream angio, reasonable luminal gain, a lot of residual stenosis. Next one.
Was a perforation from the jet stream due to jet stream or?
Yes, it was from the jet stream. Yeah, it was. Though that wasn't the cause of, that wasn't the site of concern actually. The arthrectomy sound wasn't at the mid SFA. It wasn't this point. It was quite smooth here, so we weren't expecting the perforation to be at this point. So this is post jet stream, still residual stenosis, but not too bad. Don't see any too bad.
Yeah, it's pretty good.
But,
I
yeah.
think on
So
the
next
image, do you think it looks more like the venous system that we're seeing rather than the XTRAV? If you go back to the perforation.
Go back to the
the
30,
image of the perforation, I
sequence 30.
think we're seeing the venous system rather than it extravasating into the soft tissues.
I think the burst conformity, fistula.
Yes, I think it's more like a fistula than
Fistula,
a real perforation into the soft tissues.
That's why it closed quite easily.
Yeah.
You can see that.
Yep. Okay. So show the what's the thing called? POBA. Post-mortem POBA.
CO2. So CO2 usually the perforation might be just smaller if you use contrast. So yeah, but if you use CO2, it looks more severe than it is. But anyway, I mean it's a good call to POBA. Either way.
So this is post-POBA, and then this POBA for Sterling. And then because we thought that initially I was concerned about the dedicated run at the CFA and the SFA origin, and I think it was quite satisfactory. All the videos are done with a filter in place, and now we're at a step where we've done. There's still what seems to be very sluggish, chuggy SFA popliteal. We thought it was mostly slow flow phenomenon, but on further investigation, we have an emboli in the distal tibials, and that's what we're trying to do right now. Can you just show the sequence? This is next sequence, post-POBA and drop. Thank you. Next one. Next one. Neil?
So did you capture anything in the filter?
No, we didn't have anything in the filter.
Oh, okay.
So you can see the flow wasn't very, very good. It was very chuggy. It was very slow. And despite giving some GTN, trying to break this vasospasm from the distal drug itself, it didn't really work. So we canalidated the ATA, went down to the DP, and that's what we found. Go down to the next sequence. Show the last sequence of the ATA and the DP. Some more. Go ahead. Some more.
Keep going, Neil.
Oh, keep going to the foot run, please.
Sequence 60 something.
So you can see the flow wasn't going very well as expected before the jet stream and POBA and all this. It wasn't as smooth as before, so we investigated the T-bills. Next run. Go all the way to the DP, please. Some more. Some more. Next run. Next run. Yep. So you can see that there was a wrap cutoff at the distal TB here. So we suspect that there could be a small little emboli that has flew down to the dorsalis pedis, and we're going to try to suction aspirate it out at this moment. And that's where we are right now. Where's the wire?
So what device you use for embolectomy? Suction?
We have opted to use the export aspiration from Medtronic. It's a 014 RX catheter.
Longberg.
Can I have the 6 times? Longberg,
Longberg.
Gone down. It's probably very chronic, isn't it? And it's going to be quite difficult sucking that out. Now, what I've done previously with these kind of cases is they just cut down on the DP or the PT and then trawl it out with a very small embolectomy catheter. Much easier. You get the flow running immediately.
Maybe give us a few minutes. We'll try to aspirate that out and then come back to us again, and then we see how it shows in the T-bills.
Yeah. I think our session is going to run out of time, but
Okay.
please, maybe you can show us a picture.
Yeah, absolutely.
Is there any more cases from Singapore afternoon or tomorrow? Okay, so something. Yeah, maybe later. Transmit the last. Okay, Singapore case. So how about we stay with you and see how you can suck this out. We'll stay with you.
Yeah. Yeah.
It's okay.
Time.
Got time.
It's okay.
All right. Close. All right. So I think we probably don't have time. Are you with almost there? I'll give it 2 minutes. Yeah, it's done.
I think this case gives us a good two suggestions. The first is their guide wire bias for the proximal SFA in the popliteal region is very difficult sometimes. So that we have to take care of the population. And next is their filter is not perfect. So we have to take care. Yeah, like Dr. Eder performed the proximal protection and I performed the distal protection using tourniquet. We have to take care such kind of embolization.
Where do you put up the tourniquet? Which position? You put it below?
Below the knee.
Below the knee,
yeah,
right.
It's close to their pop.
Yeah.
I think another problem is for the filter. Maybe the filter is overloaded. Maybe overloading. So we have to look back the filter because this is very long. He did very long atherectomy. So in the middle of the procedure, you have used
you put it to aspirate the filter.
Exactly.
Yeah.
We perform. We always perform.
Aspirate the filter before retrieve because otherwise retrieve and everything gets out.
I think maybe it's overloading.
Yeah.
Yeah. It's very important.
Yeah. Okay. So unfortunately, we run out of time, Singapore. So thank you for showing us your case. Very educational, dealing with how the choice of device and also dealing with complication of about. So thank you. With that, we also thank the other room finishing all the other cases. So we can't the signal. So hopefully Kevin will show us the end result of his IV. Again, we thank the other speakers today and all the panels for giving us their very good comments for all these cases. So with that, I'd like to close this session. Thank you very much.